When exposing to this typical African nose, the deformities of the nasal tip and also the nasal dorsum needs to be addressed with routine procedures of augmentation of dorsum and touching the nasal tip, but there are 2 or 3 points that must be mentioned in this case. The first one is that the width of the alar side walls will not be changed unless we can touch the base of this nasal bone with lateral osteotomy. Actually, in this deep radix and very short nasal bones, we are afraid of a collapse on the sides of the nasal bone, but if we use ultrasonic device to keep the attachments of the upper parts intact, and also if we do not plan to open the dorsum of the nose, we will experience no collapse by touching these two and cutting the edges of the nasal bone to the cheek junction. The second issue is that we have a quite short columella here, and it seems that there's no way to increase the length of the columella unless we provide some VY flaps here. But the fact is that if we can release the foot plates well from the upper parts of the lip, and if we rebuild the structure here, we will not need any skin flap to reconstruct this columella and bring the nasal tip upper and rebuild the pyramid of the nasal tip. The other issue is that we do have hooding of the ala. In these circumstances, it becomes a major question whether or not to perform transposition. Transposition will not touch or will not aggravate the problems of the hooding ala. It will only change the position of the lateral crus, filling this deep soft triangle and also recreating a much more defined nasal tip. Now, as evident here, we have performed the osteotomy, lateral osteotomy of the 2 sides. The skin flaps still have some width here, but if I touch it and squeeze it completely, we do see the real width of this bony pyramid. We've placed the diced cartilage and fascia fixated here by a bolster suture, recreating a gentle curve on the nasal dorsum, despite the fact that we had a very deep radix here. We have now a much more pleasant look in the profile view with a more defined nasal tip. In the basal view, we do have a much narrower looking basal view because of the effect of both the osteotomy of the lower parts of the nasal bone in lateral osteotomy and also creating some flaps from the sill area, cutting the sill area, bringing back the nasal ala to midline. We have had 2 cuts here, bringing back the ala much closer to midline to rebuild a more curved alar side walls. The columella is also much longer here, but the lobule also creates some appearance of a longer columella. We have had a short lobule here. We have not increased the extent of lobule too much. It is acceptable, but it helps to recreate a longer columellar illusion. That is the final appearance. There's lots of swelling in the flap, as it is evident here, but even with this extent of swelling, you have dramatic changes.